Hello friends, welcome back to yet another video on my channel Vital Induction. Today in this video I will be telling you about the common immunotherapeutic agents used during solid organ transplants, particularly kidney and liver. And what are the side effects of these drugs? What are the anesthetic concerns of these agents? Friends, let's get started. So friends, let's narrate the names of these immunotherapeutic agents used during the procedures without any particular order. The immunotherapeutic agents which are commonly used are anti-thymocyte globulins, tacrolimus, cyclosporin, azathioprine, mycophenolate mofetil, and corticosteroids, basiliximab, rituximab, and alemtuzumab. Friends, before going into these immunotherapeutic agents, let's see how these immunotherapeutic agents prevent rejection. The rejection of organ can be hyperacute rejection, acute rejection, and chronic rejection. The rejection is divided into these three categories according to the time span in which the donated organ fails. If the donated organ fails within 24 hours, it is hyperacute rejection. If the donated organ fails within 6 months, it is acute rejection. If the donated organ fails within a year, then it is a chronic rejection. Friends, all the organs in the body carries major histocompatibility complex MHC antigens, also known as HLA antigens, human leukocyte antigens. When these antigens are presented to the recipient T cells, either by antigen presenting cells of the donor or the antigen presenting cells of the recipient, then the immune response starts. This activation of the recipient immune system causes damage to the transplanted organs, either by antibody mediated, which can be by beta cells, plasma cells, or CD4 helper cells. It can be cellular mediated by natural killer cells, cytotoxic T cells, neutrophils, or macrophages. So friends, this is the reason why HLA typing is done between the donor and the recipient to minimize or to decrease the chances of rejection or antigen antibody reaction between the transplanted donor organs and the recipient immune system. Friends, the primary goal of the immunosuppression is to prevent graft rejection and to improve the function of the donated organs. Friends, there are three phases of immunosuppression. The first is the induction phase. The next one is the maintenance phase, the early maintenance phase, and the third one is the late maintenance phase or the prevention of rejection phase. Now the drugs which I have told you earlier can be allocated into different phases. Friends, the drugs which comes under induction phase are ATG, alemtuzumab, basiliximab, rituximab. Sometimes the drugs which comes under maintenance phase are also upgraded or doses are increased to bring it into the induction phase. So after induction phase, let's come to maintenance phase. In maintenance phase, the drugs which are used are calcineurin inhibitors, among which cyclosporin and tacrolimus are commonly used. And another one is anti-proliferative agents, among which azathioprine and mycophenolate mofetil is commonly used. The third one is corticosteroids, among which solimedrol is the preferred drug. And the last one is mTOR inhibitors, that is inhibitor of mammalian target of rapamycin. The drugs used in this category is sirolimus and everolimus. Friends, the drug used in this early maintenance phase are generally continued in the late maintenance phase to prevent rejection of the transplanted organ and to decrease the side effect of these immunotherapeutic agents. Friends, among this list of drugs, let's take the number one drug which is written over here and see what are the side effects or anesthetic concerns. ATG, anti-thymocyte globulins, used perioperatively, is a polyclonal antibody. It is derived by injecting human thymocytes in rabbits and horses. Friends, ATG is a polyclonal antibody. Therefore, it recognizes lot of membranous protein of cytotoxic T cells. It also acts and decreases the proliferation of B cells, dendritic cells, and natural killer cells. Since it decreases lot of inflammatory cells, the ATG is used in steroid resistant rejection. Friends, the important side effect of this ATG injection is cytokine release syndrome. This is due to initial activation of T cells. the patient will present with fever, chills, hypotension and pulmonary edema. So this is one of the important concern if you are considering injection or infusion of ATG in your patients. Coming to the second drug, alemtuzumab. Alemtuzumab is a monoclonal antibody. Therefore, it acts on particular protein over T cells, that is CD52. CD52. This is very potent and specific immunosuppressive agents. Alemtuzumab decreases the proliferation of T cell, B cell, natural killer cell and monocytes. Like ATG, this drug also causes cytokine release syndrome, but the good part is that the effect is mild. The other side effect of concern are hemolytic anemia and thrombocytopenia. Now coming to rituximab. Rituximab is a monoclonal antibody. It acts against most of the B cells except plasma cells. Rituximab is a monoclonal antibody against CD20. Rituximab is used in antibody-mediated organ rejection, ABO incompatible organ transplantation, and the side effect which is of concern is infusion-related reactions. Now coming to basiliximab. Basiliximab is also a monoclonal antibody. It acts against CD25. This CD25 is present on the T cells. Therefore, basiliximab reduces production and proliferation and action of T cells. The side effects of basiliximab are few, and these are mostly hypersensitive reactions. So now friends, coming to calcineurin inhibitors, among this let's come to cyclosporine. Cyclosporine is a fungal derivative. It is derived from Beauveria nevea and it acts by binding to cyclophilin. Friends, this cyclosporine and cyclophilin complex binds to calcineurin and inhibits its action. The inhibition of calcineurin causes reduction of N-fat cells. The reduction of N-fat cells causes reduction in the production of cytokines and proliferation of T cells. So this is the mechanism of action of cyclosporine. Friends, now coming to tacrolimus. Tacrolimus here is a bacterial derivative and it binds to a protein FK506. The name is very peculiar, and this complex then inhibits calcineurin. And the same process repeats. The inhibition of calcineurin causes again the reduction of N-fat cells, and hence the production of cytokine and proliferation of T cell decreases. Now coming to the side effect of these two calcineurin inhibitors. These two calcineurin inhibitors are nephrotoxic and causes electrolyte imbalances, particularly hyperkalemia and hypomagnesemia. These drugs, if used for a longer time, can cause neurotoxicity. The patient may develop hyperglycemia, hyperlipidemia, hypertension, and she may have facial changes like hirsutism and gingival hyperplasia. Friends, now coming to corticosteroids. Among corticosteroids, we commonly use Solumetrol. Chronic and long-term use of Solumetrol may cause Cushing's syndrome, some psychiatric disturbance, gain in body weight, mood changes, hyperglycemia, impaired wound healing and dyslipidemia. Friends, lastly coming to mTOR inhibitors. These mTOR inhibitors, we find that sirolimus and everolimus is commonly used. Friends, these mTOR inhibitors are not used immediately post-operatively. These drugs causes delayed wound healing because they decrease the activity of fibroblasts. The mTOR inhibitors are mostly used in late maintenance phase. Also, the nephrotoxicity and the neurotoxicity is less as compared to calcineurin inhibitors. These drugs are notorious to cause pneumonitis in their patients. So friends, this is all about common immunosuppressive agents used during solid organ transplants. Friends, if my video was of any value to you, then please like and share with your friends. If you are new to my channel, then please subscribe it. I regularly post such kind of interesting contents on my channel. So that's all for today. See you in my next video. Till then, bye.